Inflammatory disorders of bones and joints. Non-specific inflammatory disorders of joints. There are a wide variety of clinical conditions, all of which cause pain and stiffness, commonly grouped under the name rheumatic disease. The predominant lesion is articular. Others are extra-articular. Classification of rheumatic disease is done by American College of Rheumatology. First is diffuse connective tissue disease. Second is arthritis associated with spondylitis. Third is osteoarthritis. Fourth is rheumatic syndromes associated with infectious agents. Fifth is metabolic and endocrine disorders associated with rheumatic states. 6 is neoplasm. 7 is neurovascular disorders. And 8 is bone and cartilage disorders. 9th is extra-articular disorders. And the 10th, miscellaneous disorders associated with articular manifestations. Or simply, inflammatory polyarthritis of unknown cause. Second is degenerative joint disease. Third is infectious arthritis. Fourth is traumatic arthritis. Fifth is metabolic arthritis. Prevalence of the rheumatic disease. Estimated that more than 6% of all persons in North America has rheumatic diseases. Overall incidence of rheumatic disease increases with age. Increasing longevity increase the prevalence and more prevalent problem in the future. Adult rheumatoid arthritis. One type of inflammatory polyarthritis. Variable but usually prolonged clinical course with exacerbation and remission. Result in progressive deformities and may lead to permanent disability. Degenerative disease approximately from 40,000 years ago. Rheumatoid arthritis 200 years ago. In adult rheumatoid arthritis, the incidence is relatively common. It consists of 1.5% of the adult population, with men 3 to 1. The peak is 20 to 40 years old. The peripheral joint, especially the hand, is the most frequent site, usually symmetrical. The etiology of rheumatoid arthritis in adults, it could occur due to occult mycobacterium or ubiquitous Epstein-Barr retrovirus or some other virus. There is an exaggeration of normal immune mechanism or hypersensitivity. In 70% of patients, there are positive of rheumatoid factors and also susceptibility on MHC. There is also genetic problem of HLA-DR4 haplotype, which also could occur due to psychological factor. Adult rheumatoid arthritis, the pathogenesis and pathology. The primary target is the synovial membrane of joint and tendon sheath. In the disease synovium, it produces immune complex, therefore activate a multitude of chemical mediators of inflammation. In acute phase, PM and engulf immune complexes, therefore extrude hydrolytic enzymes, resulting in redegrading proteoglycan and collagen, and resulted in autoimmune response to joint destruction. Inflammatory granulation tissue infiltrates subsynovial connective tissue and thus becomes swollen and boggy, soften and stretch capsule and joint ligaments, leads to subluxated and luxated. Eventually, the granulation tissue create fibrosis or scar formation, and there is a joint contracture and deformity. panis, interfere nutrition, resulting in cartilage necrosis and subchondral osteolysis. Regional osteoporosis, fibrous adhesion of opposing joint, synovial in tendon result in contracture of the muscle, subcutaneous rheumatoid nodules resulted in subjected to pressure. Another, there is pericardial adhesion, myocarditis, vasculitis, disease in areas, and pulmonary fibrosis. Clinical features and diagnosis of adult rheumatoid arthritis is variable. The onset is usually insidious, but can be acute. The most common joints involved are hands, wrist, knee, elbows, feet, shoulders, and hips. It is also associated with periarticular soft tissue swelling and tend to symmetrical. In early phase, systemic manifestations such as malaise, fatigability, weight loss could occur. Among young and middle-aged patients, the most frequent local symptoms is fatigue, pain, and stiffness of involved joints. Signs of inflammation become progressively marked. Subcutaneous rheumatoid nodules occurs in 30% of patients, most common in upper limb. Clinical features and diagnosis. Deformities could occur due to muscle spasm, muscle atrophy, muscle contracture, subluxation and dislocation, late capsular and ligamentous contracture, and also rupture of tendons. There is also repeated exacerbation and remission. In radiographic, there is an evidence of periarticular soft tissue swelling and joint effusion. In laboratory, there is no specific test yet. However, there could be an anemia, elevated white blood cells count, and also elevated ESR. You could also find rheumatoid factors, and in synovial fluid, there is an evidence of leukocytes more than 2000, less viscous, low glucose concentration. Prognosis of adult rheumatoid arthritis, it is estimated that 30% of the patients could result in mild progression. Subacute or chronic course, there are multiple exacerbation and remissions, less favorable in patients in whom the process remains active over several years. Approximately 50% will recover sufficiently, 10% will remain disabled, and could also occur a widespread systemic disease such as cardiovascular and pulmonary, which could shorten life expectancy. The treatment for adult rheumatoid arthritis, there is no specific cure yet. However, aggressive treatment in early is more effective. The aims of treatment is to first to help the patient understand the nature of the disease, to provide psychological support, alleviate pain, suppress the inflammatory reaction, encourage patients to be active as possible to prevent deformity, correct existing deformity, improve function, strengthen weak muscle, and rehabilitate the individual patient. Method of treatment could also consider the psychological considerations. For the therapeutic drugs, we could use fast-acting non-steroidal anti-inflammatory drugs or slow-acting anti-rheumatic drugs, corticosteroid, and also immunosuppressive agents. The therapeutic hope is so that the biological agent that block pivotal steps in pathogenesis. In adult rheumatoid arthritis, we could also use orthopedic appliances, physical therapy, and also orthopedic surgical operations. Diffuse connective tissue disease or collagen disease. It is a chronic polyarthritis may develop from systemic lupus erythematosus, polyarthritis nodosa, progressive systemic sclerosis, polymyositis, dermatomyositis, and thrombotic thrombocytopenic purpura. In juvenile rheumatoid arthritis, the disease process is quite different in children. 90% of children, it is not the beginning of the adult rheumatoid arthritis. It has better prognosis, usually seronegative. Pathologic features are similar with adult-type rheumatoid arthritis. In juvenile rheumatoid arthritis, the clinical varieties are pauci-articular or oligoarticular juvenile arthritis, polyarticular juvenile arthritis, systemic juvenile arthritis or Still's disease, for the laboratory investigation, we could see the elevated ESR, CRP, and antinuclear antibodies. The aim of the treatment is similar to adult type of rheumatoid arthritis, temporary splints, active exercise, and NSAIDs, or orthopedic surgical operations. Ankylosing spondylitis, or Mary-Strumple disease, Reicher's disease, pyrophosphate ossificans, or rheumatoid spondylitis. Chronic seronegative spondyloarthritis involve progressive involvement of the sacroiliac and spinal joints with eventual ossification. Hip joints may be affected. Ankylosing spondylitis. The incidence is as common as RA. Man to woman is almost the same. The onset is from teen to 30 years old. The etiology, the precise cause is still unknown, and the genetic predisposition is 96%. HLA-B27 serves as genetic marker. Pathogenesis and pathology is the attack site of insertion of tendons, like ligaments, fascia, and fibrous joint capsules. Progressive fibrosis and ossification resulting in tissopathy and lead to bony ankylosis of the entire joint. Begin at the sacroiliac joint, slowly spread upward, affect capsule of the posterior facet joints, and later the intervertebral joints. The hip may be involved in systemic, eye, lungs, heart, and prostate. Clinical features and diagnosis of ankylosing spondylitis is young person, fatigue, weight loss, low-grade fever. Gradual onset of low back pain. It is aggravated by sudden movement, not really by rest, and also coexists with night pain. Morning stiffness of the spine persists into the day. And for the physical examination, we can see the local deep tenderness over the sacroiliac joints and spine. Progression of signs and symptoms, it could be continuous but may be intermittent. And after 1 year, there will be a stiff back. Spinal column progressively stiffer. The pathological fracture, difficulty to look straight ahead, may become arrested but more commonly relentless progression. And In radiographic, we could see a narrowing of the sacroiliac cartilage space and subchondral sclerosis. Ossification of the annulus fibrosis if intervertebral joints. We can see bamboo spine in late onset. For the lab, there are anemia and also elevated ESR. The HLA-B27, only 20% of these carriers experience these. The diagnosis is based primarily on clinical and radiographic grounds. Ankylosing spondylitis is like other rheumatoid, needs psychological considerations. For the therapeutic drugs, NSAIDs is not usually effective. Radiation therapy is no longer recommended. Orthopedic appliances such as spinal braces, firm and flat mattress, sudden pathological fractures, which then resulting in a temporary external fixation of hollow pelvic device. Physical therapy is essential, several times a day for the rest of their lives. Physical therapies such as swimming and running. For the surgical, spinal osteotomy to correct deformity, prosthetic joint of hip could be done. Reiter syndrome. There is an evidence of arthritis, conjunctivitis, and seronegative asymmetric arthritis. It is secondary due to venereal infection or bacillary dysentery. It occurs mostly in males. Arthritis of lower extremities. Close relation to HLA-B27. For the psoriasis, it is commonly occurs in skin, 2% associated with polyarthritis. In distal IP joints of fingers and toes. Seems to be related to psoriatic involvement of the nails. Rheumatic fever is an acute inflammatory disease that attacks connective tissues in the heart, blood vessels, and joints of children. The etiology is the sequel to infection with group A streptococci. The pathology involves intense synovitis and local transient inflammatory, which could later heal completely. The clinical feature of rheumatic fever is febrile illness with polyarthritis. In the lab, we can see elevated ESR, antistreptolysin O titer. The treatment is that there is no specific cure. Joint lesion is only transient, symptomatic, with salicylates and corticosteroid. Penicillin could also be given for acute phase and continued indefinitely in prophylactic doses to prevent recurrence. Transient synovitis of the hip joint in children is relatively common, most frequent in boys 3 to 10 years old. Clinically, there is a pain in the region of the hip, refer pain in the knee, antalgic limb, restriction of hip joint motion with muscle spasm. Progressive synovial effusion, such as bulges the hip joint, and the child prefer to lie down with the hip flex. There is systemic manifestation, however, it is still minimal. For the radiographic, there is an evidence of an effusion in the involved hip. We should also exclude more serious disease such as leg paralysis, septic arthritis, rheumatic fever, and tuberculous arthritis. Treatment is bed rest and crutches. The complication in 5% of the patient is leg paralysis within a year. Gout and gouty arthritis. Manifestation of inborn error of purine metabolism. There is an elevated serum uric acid level. It may be associated with renal disease and uric acid nephrolysis. Gout and gouty arthritis. The incidence of classic gout is relatively uncommon. Milder form is more prevalent. Male to female is 20 to 1. may present during adolescence, peak at 40s. Involves mainly joints of the feet and hands. The most common site MTP joint of great toe. The etiology that more than 5% of the patient definite familial incidence of clinical gout or hyperuricemia, presumably caused by either excessive production of deficient urinary excretion of uric acid, precipitated by infection, alcohol, dietary indiscretion, emotional injury, and cold. Secondary gout is due to leukemia and polycythemia, or CKD. Gout and gouty arthritis, the pathogenesis and pathology. There is a sudden deposition of sodium monourate crystal in the synovial membrane that has resulted in the leukocytes phagocytose the crystal and then disintegrate, then release the lysosomal enzymes, that resulting in acute and severe local inflammation. Early disease, usually the urate crystals are absorbed. Several years later, there is a nodular deposits or tophi developed in synovial membrane, articular cartilage, subchondral bone, synovial membrane of bursae, tendon sheath, and cartilage of the external ear. Chronic inflammatory reaction resulted in destruction of cartilage and subchondral bone, and it resulted in progressive degenerative changes of the joint. Clinical features of gout is vary in a series of attacks of acute gouty arthritis over a period of years. Acute gouty arthritis, chronic tophaceous gout, chronic gouty arthritis, pseudogout. Acute gouty arthritis, it is an early stage. The warning symptoms are mood change, constipation, diuresis, or intense pain of the joint, swollen and acutely inflamed, lasts for several days or several weeks, and after the attacks the joint returns to normal. For the chronic tophaceous gout, after several years, it happens if 50% of a patient develops tophaceous gout. There is a tophi, persistent of deposits of urate crystals surrounded by chronic inflammatory tissue and may impair joint function. The cartilage, there is a local destruction and resulted in local osteoclastic resorption. In extra-articular, there is a carnon bursae, tendon sheath, and cartilage of external E. It is usually painless. In chronic gouty arthritis, there is an articular and subchondral tophi. It is a progressive degenerative arthritis with chronic joint pain. There is swelling and stiffness. Superimposed attack on the chronic arthritis. Pure urate deposit equal to radiolucence and secondary deposition of calcium in the soft tissue results in a radiopac. In laboratory diagnosis, we could see hyperuricemia, urate crystal from synovial fluid by polarizing microscope, and tophi develop only in half of all patients with gout. The treatment is the drug that should be continued for the rest of the life. For the acute gouty, colchicine, hourly and the severe pain is relief up to 12 hours. For the chronic gout and gouty, we could use uric or suric drug such as probenecid, sulfentrazone, or arloprenol for the rest of the life. In pseudogout, there is a crystal-induced arthritis composed of calcium pyrophosphate dehydrate. It is relatively common and primarily affects adultery. There is a recurrent painful attacks of acute arthritis. In radiographic, there is a calcium deposit within articular and meniscus. In a third of the patient, there is a rapidly progressive and degenerative arthritis called pyrophosphate arthropathy. Rheumatoid disease unit. It is very and complex nature of rheumatoid disease. It is a combined team efforts of rheumatologists, family physician, orthopedic surgeons, rehabilitation physician, physical and occupational therapists, and medical social workers. Splendid setting for undergraduate and postgraduate teaching. provide powerful stimulus for both clinical and experimental investigation or research. Hemophilic arthritis. It is a classic hemophilia and Christmas disease. The effects of first-stage clotting mechanism of blood. The incidence is related with hemophilia A, hemophilia B, and X-linked disease. The pathogenesis and pathology involve blood in synovial joint. In hemophilia, there is a failure to clot, irritation of blood phagocyted, inflammatory granulation tissue creeps across the surface, granulation tissue burrow under cartilage resulted in collapse of the joint surface, and there's also a repeated hemorrhagitis. Clinical features and diagnosis. We should see the family history, previous history of abnormal bruising or excessive bleeding, vague feeling of joint discomfort, repeated hemarthrosis, and in radiographic there is a soft tissue swelling. And for the lab there is normal bleeding time but prolonged PTT. The treatment is for the emergency hemophilic arthritis. We should give immediate treatment that can prevent late sequelae, such as IV therapy of factor 8 or 9. Home care programs, splint the joint to prevent further bleeding, physiotherapy, surgical sinupectomy, radiation sinupectomy, and for later stage reconstructive operations, and also daily prophylactic treatment. Thank you for listening.